Yes.
Yes. Okay. Okay. So I'm going to now speak for the next 25 minutes on the subject of diabetic neuropathy, which is my favorite subject. And of course, it is the Cinderella complication. And the reason it is referred to as a Cinderella complication is because it is the forgotten complication. And particularly for people like Shanaz, you know, ophthalmology background, you have really fantastic equipment available to you to detect diabetic retinopathy at the very earliest stages. And even for the kidney, we have, you know, a really easy test, microalbuminuria, EGFR, which allows you to detect relatively early disease. But for diabetic neuropathy, we still are stuck in the Stone Ages, in that we rely very heavily on clinical examination, monofilament examination, which actually detects disease far too late. And so therefore, the majority of the time we spend is in dealing with not the early stages, but actually the consequences of diabetic neuropathy. And those consequences of diabetic neuropathy are as a result of sensory, motor, and autonomic nerve damage. And the major consequence, of course, is a foot ulcer. And if you have a foot ulcer that doesn't heal, becomes infected, then you can develop amputation. So the lifetime incidence of a diabetic foot ulcer in a patient with diabetes is 19 to 34%. But we know that up to 90% of people have diabetic neuropathy. And we're actually really quite good now at healing those ulcers. So 77% of people with a foot ulcer will be able to heal those ulcers within a year. But because of the underlying neuropathy, 40% will recur within a year. And unfortunately, if your patient has an amputation, which you can see here, this is Mr. von Bergmann in Berlin, 1901, and I can tell you 2020 is no different in terms of the operation. What you find is that post-amputation, the mortality is extremely high. So the 5-year mortality for somebody who's had an amputation is 70%. And if you have end-stage renal failure at that stage, it's actually 74%. And furthermore, just to emphasize the very high mortality associated with diabetic foot ulceration, this is for an article that I put together where we compared the 5-year mortality in a patient with diabetic foot ulcer, which you can see is 42.2%. Compare that with common cancers. So prostate, breast, colon, Hodgkin's, bladder, and lung cancer. In fact, these cancers have a lower mortality than foot ulceration, and only lung cancer has an equivalent mortality. Similarly, if we look at the 3 other big causes of major morbidity and mortality, COPD, post-MI, stroke, they all have lower 5-year mortalities compared to a person with a diabetic foot ulcer. So what is it that is causing diabetic neuropathy? Well, it's very clear that we, for a long time, really were focused on the consequences of hyperglycemia. But it's clear now that dyslipidemia is playing an important role, and inflammation is also now an increasingly recognized mechanism by which nerves become damaged. And I will share with you data suggesting that actually if we intervene in the dyslipidemia axis and the inflammatory signal axis, we can actually do something about diabetic neuropathy. But currently, we have a big problem, and that is that whilst we have all of these pathways in the lab, very little has been translated into, or actually nothing has been translated into therapy for our patients with diabetic neuropathy. We do have 3 treatments for painful diabetic neuropathy, but we have no disease-modifying treatments. So if you look at today, if you did a search on clinicaltrials.gov, there have been actually 138 phase 3 studies in diabetic neuropathy, predominantly in diabetic painful neuropathy, for which we have 3 approved drugs. which are duloxetine, pregabalin, and tapentadol. But for disease-modifying therapies that might block the progression of diabetic neuropathy or reverse diabetic neuropathy itself, actually, there are no drugs that are currently approved. And so you have to ask the question why that is. And I believe that a major, major reason for this is that we are using the wrong tests to assess whether or not a drug works. And so we rely heavily on symptoms and signs and nerve conduction. And these, unfortunately, have failed time after time in terms of as endpoints to show us that the drug works in patients. So this now brings me nicely onto what I believe is a test that might be able to help us. And that is an ophthalmic instrument called corneal convocal microscopy. So this is how simple it is to do. This is local anesthetic to the eye, and simply the microscope touches the front of the cornea and we are able to image nerve fibers, small nerve fibers in the cornea. And we're able to scan through the cornea and pick up the subbasal nerve layer, which we can quantify. Now, it's taken us a long time to actually reach where we are now in terms of applying this technique in clinical trials. But the work started in 2003, where we showed that if you take healthy controls, and these white lines you see are actually the nerve fibers, the small nerve fibers, the C fibers, you can see there are many of those in a control subject. Whereas in a patient with diabetic neuropathy, severe diabetic neuropathy, you can see this is markedly reduced to 1 to 2 fibers. And if you actually then take it in groups of people, you'll see that in healthy controls, the average nerve fiber density is around 45, whereas in people with diabetic neuropathy, particularly those with severe neuropathy, is reduced down to 15 or 20. And the same applies for nerve branch density, which is the number of branches that come off these main nerve fibers, and also particularly nerve fiber length. So you can see averaging controls around 14, 12, 13, whereas in those with severe neuropathies down to 4. So this is where we started. Subsequently, we actually showed that if you measure neuropathy not using the monofilament or nerve conduction, but you actually measure neuropathy using CCM, then in fact, you can turn the complications of diabetes on their head. That is, that no longer is retinopathy considered to be the first earliest complication or microalbuminuria, but actually neuropathy measured using corneal confocal microscopy occurs earlier. So we've done this initially in 53 patients with type 1 diabetes, but we now have big cohorts with type 2 diabetes showed exactly the same thing. So if you take healthy controls, diabetic patients without retinopathy, background diabetic retinopathy, and proliferative diabetic retinopathy, actually, we can already see in patients who have no diabetic retinopathy a loss of corneal nerve fibers. And this, of course, then progresses with the severity of retinopathy, but the key important message is that the people without diabetic retinopathy on fundus photography already have a reduction in corneal nerve fibers. Similarly, patients without microalbuminuria already have a reduction in corneal nerve fibers compared to healthy controls. And people with impaired glucose tolerance, these are people without diabetes, they also already have a reduction in corneal nerve fibers, corneal nerve fiber density, branch density, and length. And children with type 1 diabetes who you think do not have evidence of nerve fiber damage. We actually studied a large cohort of 64 children or adolescents aged 14 years with admittedly poor glycemic control, but that's what you find in children. And what we found is that already in these children with type 1 diabetes, there is a reduction in corneal nerve fibers, and there is also expression of what we think is inflammation, actually, by the presence of these small Langerhans cells. And so if you look, actually corneal nerve fiber density, which is the main nerve trunk, was not different. But the more distal branches and nerve fiber length was significantly reduced in children with diabetes, type 1 diabetes, compared to healthy controls. And furthermore, there is actually the expression of these small cells called Langerhans cells, which are dendritic cells, antigen-presenting cells, which are increased in people with kids with diabetes compared to healthy controls. So this is an early process that could be picked up using corneal convocal microscopy. And the other big manifestation of diabetic neuropathy is painful diabetic neuropathy. So at least a third of people with diabetic neuropathy will get pain. Why do they get pain? Because they have damage to the small nerve fibers. And in fact, what we have shown is that people with painful diabetic neuropathy actually have more small fiber damage compared to patients with painless diabetic neuropathy and healthy controls. So you can see nerve fiber density, branch density, fiber length, inferior wall length particularly, are all more seriously damaged in those with pain compared to those diabetic patients without pain. And furthermore, this correlates with severity of pain and quality of life in these patients. The other big manifestation that we come across in clinics is erectile dysfunction. Again, people think about erectile dysfunction and they think of two things: autonomic neuropathy and testosterone deficiency. We actually have taken a cohort of people and we've scored their erectile function according to the erectile function score into minimal to most severe. And when you actually relate that to total testosterone or free testosterone, actually you find very little relationship in the amount of testosterone and the severity of erectile dysfunction. However, look at corneal nerve fiber length and density. You can see that in those patients who have the least severe erectile dysfunction, they have a higher level of corneal nerves compared to those who have the most severe. And actually, corneal nerve fiber density and corneal nerve fiber length correlate with the severity of erectile dysfunction. So it's fine doing these tests, but can we do something for diabetic neuropathy? Well, there is something we can do, and this is based on what is now a famous study published in the New England Journal of Medicine 15 years ago, which showed that for diabetic neuropathy, much like retinopathy, nephropathy, cardiovascular disease, actually the risk factors for diabetic neuropathy are poor glucose control, yes, but also cardiovascular risk factors, hypertension, smoking, having a higher BMI, having higher triglycerides, possibly also having higher total cholesterol. So can changing these risk factors improve or prevent diabetic neuropathy? So if we look, HbA1c and change in HbA1c is clearly important. But when we look at data, and this is a Cochrane review that looked at the benefits of improving blood sugar control on preventing or treating diabetic neuropathy, what we see is that in type 1 diabetes, there is a benefit, and this is highly significant. But in type 2 diabetes, where we have actually bigger trials, more patients in the ACCORD study, in the VADT study, in the ADVANCE study, actually no significant improvement. And you have to ask the question, why? Well, it comes back to crossing this valley of death. So what you have to ask is, what tests were used in the type 1 trials as opposed to type 2 trials? And what is clear is that nerve conduction, which actually in the right hands does work, actually showed an improvement. But what did they use as endpoints in these trials? Symptoms and signs. And that's why they were not able to show that there was an improvement. So I don't want you to go away with a message that in type 2 diabetes, improving glucose control doesn't work. It does work, but it's the way you test it that matters. And in fact, we now have a study we did in Qatar looking at the benefits of, in type 2 diabetic patients, of either GLP-1 therapy or basal bolus insulin. So we actually took type 2 diabetic patients who had poor control of diabetes despite being on metformin and a sulfonylurea. So the average HbA1c was 10.5%, 10.6%. We then randomized them to receive once weekly exenatide or basal bolus insulin. Actually, once weekly exenatide with pioglitazone. And what you see is a marked and good rapid reduction in HbA1c to around 7% in both groups. And then we did corneal confocal microscopy. And what we show actually is that over a year, there was an improvement in corneal nerves. And in fact, branch density particularly, but also fiber density and length improved significantly, whereas vibration perception and pseudoscan did not. Hypertension, well, if you think about hypertension, this is a major risk factor. And in fact, this is, we know hypertension, how does it cause nerve damage? Well, it does so by damaging the small vasa nervorum of the blood vessels. And this is actually my very first paper where we showed that the microvasculature in the peripheral nerves of people with diabetic neuropathy is abnormal. So there is basement membrane thickening, endothelial cell hyperplasia, hypertrophy, luminal narrowing, and all of this actually reduces oxygen diffusion into the nerve. And what we showed is that this progressive pathology of basement membrane thickening, luminal narrowing, and reduced blood flow actually reduces the oxygen diffusion into the nerves. And this correlates with nerve conduction, vibration perception, thermal discrimination, and myelinated nerve fiber density, highly significantly. And more recently, we've shown that if you have hypertension in people with type 1 diabetes, you actually have greater nerve damage compared to diabetic patients who do not have hypertension. And previously, we've shown actually that if you give a diabetic patient who's got normal blood pressure, no microalbuminuria, an ACE inhibitor, over 12 months, you can actually improve their neuropathy. Motor nerve conduction goes up, M wave amplitude goes up, and F wave latency improves. In terms of lipids, typically most people think of lipids and they think of atherosclerosis. But you can see from this data set that there is clearly a relationship between higher triglycerides and higher total cholesterol and diabetic neuropathy. So are there data to suggest that using statins or fibrates might be helpful? Well, this is actually a large study published now 6 years ago, of a nationwide matched group of 15,000 people who were on statins compared to 47,000 who were not on statins. This is diabetic patients. And what they showed very clearly is that if you were on a statin, you actually had a 40% lower risk of developing diabetic retinopathy, a 34% reduced risk of diabetic neuropathy. And in fact, sensory loss and erectile dysfunction was significantly lower if you were on a statin and compared to if you were not on a statin. And fenofibrate. If you give fenofibrate to patients with type 2 diabetes, you can actually reduce their amputation risk by actually almost 50%. Omega-3, which is used to lower triglycerides, and people use it post-MI. This is a study in type 1 diabetic patients after receiving this therapy. Look what happens to their corneal nerves. They improve significantly corneal nerve fiber length and branch density over 12 months. And we've actually now shown that there is a relationship between PCSK9 levels and actually using a PCSK9 inhibitor in terms of nerve regeneration. So if you just take people who are obese without diabetes, what we have shown is that there is a relationship between the higher the PCSK9 levels, the more nerve damage there is. So corneal nerve fiber density, corneal nerve branch density, and corneal nerve fiber length are lower if you have a higher PCSK9 level. Okay? Now, if you take people with familial hypercholesterolemia and you give them a PCSK9 inhibitor, evolocumab, actually what we find is that there is an improvement of nerve fibers. We have now got actually 24-month data showing a progressive increase in nerve fibers at 6 months, 12 months, and 18 months. BMI is an important risk factor for diabetic neuropathy. And what we now have is data showing that if you take people with diabetes and you perform bariatric surgery on them, no doubt, we have lots of improvements in terms of, improvement in BMI, significant reduction in systolic blood pressure, diastolic blood pressure, HbA1c. Lipid profile improves up. But what we now are beginning to show is that there is an improvement in nerve fibers, corneal nerve fiber density, branch density, and length, all significantly improved 12 months after bariatric surgery. Finally, inflammation, which we know plays a key role, which probably lies at the heart of the abnormalities in hyperglycemia and dyslipidemia. So 7 years ago, I was approached by Tony Sarami, who had invented actually a drug to switch off inflammation in peripheral tissues. This drug is derived from erythropoietin, and it actually blocks inflammation at the tissue level. And what they had found is a peptide fragment of erythropoietin latched onto something called the innate repair receptor. And when it does this, it switches off inflammation and induces tissue injury and induces tissue repair in a whole range of animal models. And this drug is called ARA290 or sabinatide. Now, subsequently, we did a phase 2A study where we took patients with type 2 diabetes with pain and we gave them ARA290 over 28 days. And what we found actually is that there was an improvement in nerve fibers. There was also a reduction in pain scores in people on ARA290 compared to placebo. And now we actually have in the planning a phase 3 study for ARA290 or sabinatide in diabetic neuropathy. Thank you.